Okay, domain two, coding documentation. Okay, so we will be getting almost 20 to 30 percentage from this particular topic. Okay, so domain two is on coding documentation. And in this, we will be covering the topics like identifying and the corrections of gap between the documentations and resolving the conflict and documentation in the medical records. And we'll be checking on the reviewing and analysis of documentation which is getting recorded, then understanding the documentation requirement for the specific diagnosis and procedures. Okay, so these are all the things we will be covering up in this domain 2, which will be like a 5 small topics. So I have taken this all together in one particular slide. Okay, so we'll discuss one by one topic so that you will have the clarity. And even for this, whatever the classes we are taking, we have the domain 2 questions separately. You can try to attempt the questions in that as well. Okay, so coming to the topic, and the first point here is on, so as I told, these 5 topics which we are going to, sorry, the 6 topics which we are going to discuss in deep into the documentation. So first thing is on review and analysis of health record documentation. So identify the type of record. So first, what is the step when you're going to come for the documentation analysis? What we are going to do is that we have to identify what type of record it is. Okay, that is very, very mandatory. Okay, so I should know whether it is an inpatient or outpatient or any other services, like whether it is going to be a consultation or progression note, or it is going to be some hierarchy coding or ancillary coding. So I need to classify what type of note it is, what type of patient I'm encountering. Okay, that is what very, very mandatory in the documentation. If you know that what type of documentation it is, then only you can be able to differentiate the guidelines in the same way. Through the guidelines, you can be able to do everything. Okay, so that is what the main thing when it comes for the identifying the record. And second thing is on operative note reports. Okay, so this is another part where it is one side we are talking about inpatient, we are talking about diagnostic reports or pathology report, anesthesia report. The other side, surgical procedure. Why? Because when it comes for the inpatient, especially, we completely rely on the surgical reports. Okay, what type of surgery it is performed, what type of procedure it is performed. Okay, that is what a very, very mandatory one when it comes for the surgery related procedures. Same way, diagnostic report. So if you see, these are the diagnostic specialties when it comes for radiology, pathology, even some of the medicine procedures also which comes under the diagnostic reports. So I should be able to identify that what type of documentation it is. So as I told, whether it is an inpatient or outpatient, or it is a surgical note or therapeutical note, or it is going to be the diagnostic related notes. Finally, discharge summary. It is very, very mandatory, especially when it comes for the inpatient coding. Without discharge summary, you will not be able to arrive any set of codes. That is a very important thing when it comes for the inpatient coding, especially IPDRG. As I told, the based on the discharge summary only, you will be able to identify what is a POA and what is a HAC, which means like present on admission condition, and what is the principal condition, and what is the secondary diagnosis, and what would be the hospital acquired conditions in that, which are going to be the major morbidity condition, or which are going to be the complicated and comorbidity conditions. So this all you will be able to identify with the help of discharge summary. Again, this discharge summary has this unique way of following the guidelines based on the UDHHS. Okay, those are the guidelines of guidelines owners who will be providing all type of guidelines based on how the discharge summary need to be considered, and what are the documentations are required for the discharge summary, and how we are going to code. So all these details will be provided through the discharge summary. So when it comes for the record, okay, when it comes for the records, we should be able to identify and differentiate the records very clearly. Then only we will be able to follow the guidelines, appropriate guidelines according to the specialty or according to the classifications of the patient. Then comes the second thing is on completeness. Okay, completeness of the documentation. Now I have the documentation. Yes, some words are, some phrases are combined, some paragraphs are combined. So if the paragraphs and some phrases are combined in a documentation, should I consider the documentation or not? Yes. For that, we need a set of rules, which means like we call it as completeness. So starting from A to Z, everything need to be documented. So these are the list of things like patient identifiers, name, like your name, date of birth, and the MRN number, or patient ID, patient group ID, okay, reference number. This all should be available in the documentation. That is one important thing. That is a patient identifier. The second thing is like date and time of the service. Very, very important. DOS is very, very important. Because of the DOS only, you can able to use the global period CPTs, global period modifiers, and other set of services, and which are certain modifiers which you cannot be used in the different dates. So these all come to the conclusion with the help of the date of service. Then provide a signature or authentication. That is one of the important thing where you need to provide a sign. Without a provider sign, the documentation, entire documentation, whatever is given is incomplete. Again, the reason, which means like the reason for the visit. So chief complaint and history of the patient illness, this all need to be available in the documentation. Finally, assessment and plan clearly that need to be documented. Okay, these are all the complete documentation which is required when it comes for the coding documentation. Without this, you will not be able to proceed further. Then the next one is like evaluate the clinical accuracy. Yes, that is also very, very mandatory. So if say for example, if a physician, if I'm going to the physician and if I'm going for a headache and he is going to order me something unrelated, unrelated procedures, which is going to pay for him more, that shouldn't be happening. That kind of fraudulent or that kind of like improper malpractice should not be happen. So to confirm that yes, the patient has come for this particular condition, which is very medical necessity. Based on that medical necessity, the entire procedure is performed. That performed procedure is supporting the documentation, and documentation is related to the medical necessity. So this is like a flow chart. So this is complete like a flow chart where the documentation should be very clear and the documentation should be supporting to the medical necessity, okay, or the specific diagnosis are consistent across the record. So this all we need to verify. Does the documentation report medical necessity, or diagnosis specific and consistent across the record? Do the procedure match the clinical findings, like ultrasound performed for a suspect of ectopic pregnancy should have been correlated clinically noted. So the condition which has come for that only, the procedure should have been performed, the clinical evaluation should have been done. That is very, very mandatory. So for namesake, I cannot consider something. For namesake, I cannot give some procedures on some test or some laboratory test or some pathological test by my own. So that should be completely related to the medical necessity. Then next one is the coding and compliance check. So when it comes for the coding and compliance check, these are the four important things which comes for, especially when it comes for the coding, and when it comes for the compliance check, the law, which you are talking about, Stark law, anti-kickback awareness law. Okay, these are very important laws which we need to be aware of also. The first thing is on the coding. Yes, we need to ensure whether CPT is coded or ICD is coded, sorry, IPIX is coded. This both need to be verified. Okay, simply by keeping the ICD, I cannot code anything, or simply by CPT, I cannot who go for the payment or reimbursement. I need to ensure both CPT and ICD as well as modifier is coded. When it comes for the modifiers and equips, whenever it is mandatory and whenever it is applicable, yes, in that situation I'm going to use. Apart from that, CPT and ICD is very, very mandatory. Without that, I cannot consider that as a coding. So that is the first coding check. And it comes for the compliance. So we have a two set of uh, laws. One is Stark law. You might have heard about Stark law. You have any idea on the Stark law? Did you heard about Stark?
No, sir, I didn't get it.
Oh, okay, no problem. What about kickback?
No, sir.
Okay, you never have. So you do not have these complaints in your previous organization?
No, sir, I didn't heard of these two things in that.
Okay, it's a nothing. Just like it will prohibit. Okay, where uh, a physician cannot refer the patient. Okay, saying that what is that? He cannot take his own. Like he cannot. It will control. Is a kind of law. It will control the extra payments, and it will control the patient is not misused by the physician. Okay, so it is a set of United States federal law. Especially, it is also called as physician self law. Okay, that will prevent the physician from referring the patient for some other entities. Usually, what happens? The payment will be more for this Medicare and Medicaid patient, especially when the physicians are going to receive the amount. If they're performing for the Medicare and Medicare patient, the payment will be more for them. So sometimes when the patient is coming with some other insurance like TRICARE or commercial, okay, like that, some other Athena, some other insurance, if they're coming, they cannot manipulate or refer the patient as Medicare or Medicare services, because that will make patient extra payment and make the physician as a beneficiary. So to avoid that, we go through this particular law is called Stark law. Okay, we'll be discussing furthermore in the Stark law that will help you out like how the star class is going to work and how we are going to use the star class. Okay, well, like this has a separate slides for this. I will be taking you that as well. Okay, the next one is anti-kickback statute. Okay, so this is something it will ensure. You might have heard about this, like gifting to avoid the tax and all. People what they do, they will give it as a gift or cash or like whatever to tell some referral amount like that they used to provide. Okay, so to avoid this, okay, so especially you cannot negotiate the payment. It's a kind of illegal. Okay, illegally you cannot negotiate the payment like such as cash or gift you cannot provide, or you cannot make some kind of a mutual understanding, mutual payment understanding and mutual treatment. Okay, so that will become improper service and become it becomes like a business instead of becoming the services. Okay, to avoid that, we follow these two in the compliance. Yes, as I told, we'll be discussing little more in the star clan kickback. Okay, like further I will be taking you some of the slides in the domain 4. In that time I will tell you in more additional brief notes on them. Okay, so this is what it keep a control for the physician simply. Okay, so there's a fourth thing which is very important for the documentation. So that is following the star law and anti-kickback awareness law. These are important two laws. Then audit readiness. Yes, this is also more important. Yes, I'm doing the coding, I'm doing the ICD, I'm appending the modifier, all this been done. Finally, when I'm coming for these complaints also came across the complaints. But when I go for the payment, due to some reason I may get back. Due to some what is that upcoding or downcoding, what happens? You may get denied. So we will be in the confusion and we have to start from the scratch and we have to analyze that. Okay, to keep that in the control, to make sure whatever the payment and reimbursement need to be done in a proper way, it is always better to do an audit. Okay, so we need to ensure we are not making any duplicates, we are not doing any copy paste, or we are not having the upcoding or downcoding. Okay, this all will be controlled, okay, mitigated, or it can be controlled in the checkpoint of audit. Okay, so that is what audit readiness, which will tell, yes, this report is ready for the payment now. We don't want to further go for one more type of set of analyzation. Now it can be done for the payment. Okay, that kind of picture where you will be getting through the audit readiness. Okay, then next important topic. So this is what we have seen so far on the documentations. Okay, review and analysis, health record documentation. These are the 5 mandatory points. So as I told, so first we need to check for the identify the type of record, and second is like check for the completeness. For completeness we have certain set of guidelines, and third is the evaluate the clinical accuracy, and fourth is the coding and compliance check, fifth is the audit readiness. Okay, so next important topic in the documentation, so the domain 2, that is resolve the conflict or ambiguous documentation in the medical record. Okay, resolve conflict, confusions, and ambiguous means which is ambiguous, we can tell like improper usage, okay, of documentation. So something like non-specific documentations for the ambiguous, we call it as ambiguous documentation. So conflict in the documentation. So conflict in the documentation means two or more entry contradictory each other. So certain conditions, okay, especially I've given two example you can see here, sepsis and SARS. See, these are interrelated. These both are interrelated. When the patient is coming for the sepsis in the ED, okay, mostly will encounter this ICD when it comes for the sepsis, especially in the IPDRG, we'll always encounter clinical features of the condition, which we'll be studying in the further slides also. So here, the main thing is like sepsis, the patient is coming as a sepsis, then he is ruled out in the discharge summary as a systemic, what is a systemic disease, okay? We call it as SIRS, systemic inflammatory, what is that? Systemic inflammatory, some disease it will come. I forgot the exact abbreviation. Systemic inflammatory, so SIRS, systemic inflammatory response syndrome. Yes, systemic inflammatory response syndrome. Okay, if you see, both are going to be almost similar. Okay, sepsis and the SRIS, both are going to be almost similar. But when the patient is coming for, when the patient is coming as admitted, he was addressed as a sepsis person. Okay, but when he is getting discharged, they're telling ruled out. Ruled out means what they're telling is diagnosed, is finalized, is having SIRS. Okay, both are, if you see, both are similar. Only one small difference. All the sepsis is SRIS. Okay, all the sepsis are systemic inflammatory response syndrome, whereas not all the systemic inflammatory response are going to be sepsis. Okay, what they're trying to tell you, like under the SRIS, there are so many conditions may come, but when you get a sepsis, definitely you are going to get the SRS. Now, what is the confusion we may have? What we may think? We may think both are different. What we think? we may think both are different. Okay, sepsis is different, systemic inflammatory response syndrome is different. But here, as I told, when you get sepsis, your systemic inflammatory response will be more. It is like your kidney failure or your organ failure or your system normal morphology and physiology. Everything will be deferred because of the sepsis. Your immune system will be activated there. Which this all happened because of the sepsis. That is why you are getting systemic inflammatory response syndrome. If you take vice versa, if I have the systemic inflammatory syndrome, means I can have the hypersensitivity also, or I can have other human infections also, other type of infections also. So that may also cause me the, so that may be the reason for the systemic inflammatory response, which means a SARS. Okay, but here both are going to be similar because you get the sepsis, you get SRIS. But if you get SRIS, you need to further diagnosis what type of infection it is. That is a small difference. As I told, all sepsis is not SIRS, but not all SIRS is sepsis. Okay, that is what very, very important thing we need to be very clearly understanding. Okay. And as I told, sepsis is going to be like the inflammation in your system. It is going to alarm. It is going to trigger. Like usually, it may be the bacterial infection or viral infection. Sometimes it may be fungal infection. Especially, it will threaten you to the life. Okay, your life-threatening medical emergency. We will call it as. Okay, so temperature will be high. Your heart rate will be high. Your respiratory rate will be high, and your WBC rate will be high. These all are because of the sepsis. Now, when you get the sepsis, automatically you will be under the SRIs. Okay, as I told, SRI is a non-specific body response. It may be caused because of anything. We can tell because of trauma also, you can tell because of some other infections also, you can tell. A burn, if you're getting also, that is also systemic inflammatory response syndrome only. Like inflammations like pancreatitis or hepatitis or major surgeries when they're doing. These all are going to be a cause for SRIs. Okay, so what is the final conclusion here? Don't think that is a different condition. Both are same condition. You keep coding for the, you give the payment for the sepsis. Okay, that is what main thing here. Then second thing is like, see one more example, AKI. Okay, AKI and CDK. AKI is acute kidney failure, whereas CKD is chronic kidney failure stage 3. So if you see, both are going to be some of the conditions. Okay, both are going to be some of the condition happen in the kidney. And what it is going to do, it is going to make sure your kidney function is going to be lost, which means it is going to be reversible. Okay, your kidney function won't be normal. So acute kidney injury, usually when the kidney function is subnormal and it will recover in some hours. It is like 1 or 2 hours, you'll be come back to the normal condition so that you will not have the kidney problem, which means like it will be like alarm for you. Okay, whereas chronic kidney disease, slowly that failure will be progressed. Okay, what happens? The function, whatever the normal kidney function need to be happen, that will be slowly progressing and it will end up in the months to year. Finally, it will develop to the end stage renal disease and you will be end up with your life. Now, if you see, both are almost similar. It is not like completely different. Okay, both are almost similar. Only difference is like in AKI, you will be recovered faster, where in chronic kidney disease, it is very often it will go for the next stage, like for the chronic kidney disease 4 or 5, or finally to the end stage disease, it will go. But internally, both are going to be the same. Okay, now when the patient is coming for the AKI in the initial encounter and he is diagnosed finally in the discharge summary as CKD, we don't want to confuse. It is better to go with the AKI. We are not mandatorily, we have to code the chronic kidney disease thinking that this is a final condition. No, we have to go with the AKI. That is what they're trying to give a comparison here. Then left versus right mismatches. Sometime when you get a documentation telling that right and left, there is a mismatch. We can go back and query the for the provider for the documentation whether the procedure is performed or
Sir,
not.
one small doubt, sir.
Yes.
If in documentation, the documented like AKI in progress and CKD also confirmed, means we have to code only AKI as N79. That's it.
Yes, we have to go with that. Maybe for secondary diagnosis, if edit is not coming, and when it comes for the exam point of view, Mona, yes, it is
Okay, sir.
always better to go with the AKI. Okay,
Okay, sir. Okay, sir.
because that becomes a secondary diagnosis.
Okay, sir.
So
CKD becomes a secondary
secondary
diagnosis.
diagnosis. Okay, we
Okay.
always go by the principal diagnosis only. Okay, so in
If
exam point of view,
another small doubt, sir, if there
yes.
is any combination codes with diabetes or else anything, means we have to mention CKD along combo codes or else we have to skip that those
No, no,
combo
no.
and
You are good question. That is very, very good question. Yes, we need to go the combined coding. Okay,
okay, along with the
combination code.
combination code we have
Yes,
to code AKI too.
AKI. See here. When the patient is having diabetes with the CKD means he is not going to come under AKI. Okay.
Yes.
As I told you, AKI is going to be the temporary. Okay. It will happen suddenly and it will disappear suddenly.
Okay, sir.
That AKI can become CKD in future.
Okay,
Okay.
sir.
That possibilities are there. Okay. Now, when I admitted in the hospital, I am a AKI patient. Okay. During the course of treatment in the hospital, I've been getting treatment for the acute kidney injury only. But finally, when I'm going for some tests, say for example, GFR, I'm going to take glomerular filtration rate, I'm going to check. When I'm checking the GFR, finally I came to know I'm having the stage 2 or stage 3. So what we can tell is like that becomes a secondary diagnosis because primarily he had an kidney injury, which means he had a problem of AKI, then that is developed into the CKD. When it
CKD.
developed into the CKD, if CKD1, CKD2 means no issues and all. Okay, I
Okay.
don't want to consider that as a secondary diagnosis also. Even that CKD1 and 2 can be reversed. Okay,
Yeah.
but from the CKD3, it is not reversible. We call it as irreversible. The progression of damage is going to be over the time. It is like the damage is
Yes.
going to happen faster.
Yes.
Okay, so that is the reason. If you see patient who is coming for AKI, why I should not be coding the CKD as a principal diagnosis means if the person is having the principal diagnosis, why I need to worry about AKI there? AKI is not
Yes.
related at all. I can remove that AKI. Okay. So
Ah,
AKI is going to be the starting point. In the ending point, it is going to be the CKD. So which means like I can tell partially, I can tell, I cannot tell 100%. I can tell CKD as a hospital acute conditions. Okay.
okay, sir.
Even that I cannot relate. I can consider for the secondary diagnosis. I cannot tell as an acute. Why I cannot tell as an acute means because he had a kidney injury, he is getting the chronic kidney disease. Okay, say for example, same kidney injury is there, he is going to have the heart failure. Okay, in that situation, I can think heart failure as an hospital acute condition because there is a chances as we discussed, like as you told, diabetes patient when the diabetes patient is coming with the CKD. Okay, there is a high chances where he can get to end up with the CHF also.
Yes.
Okay. So which means like heart failure also you may end up. I cannot tell congestive severe heart failure, other type of heart failure like systolic heart failure or
That's
diastolic
fully
heart failure.
correct.
Yes,
Yes.
that may be possible. That kind of possibilities will be there. Okay. So that
Okay.
is a good question. So when you analyze this pathophysiology, when I have the acute, there is a possible of chronic. But when I have the chronic, there is no possibility of acute. Okay. When
Okay,
I'm
sir.
coding the combination code, in that scenario, it is very clear. Yes, I need to code the combination code for the chronic kidney disease because I have the combination code. In the same time, when I'm able to go with the combination code, there is a less chances of getting the AKS and principal diagnosis there. Okay. So either he has to admit it as a chronic kidney condition per patient or he should be admitted as the acute kidney injury patient. Okay, any one should be there. Otherwise, if he is going to get a diabetes, means that default tells you, the documentation itself tells you he is not a AKA person, he is a CKD person. Okay, so that is what the
Yes.
small difference will be. So that yes, as you told, the way you are thinking is really wonderful. So when it comes for the IPDRG, when I'm coming for the selections of the code, this kind of, especially when it comes for the ICD and when
Yes.
it comes for the secondary diagnosis, this kind of confusions are coming. Okay,
Yes.
so that can be avoided. Okay, even we are started the IPDRC, like this kind of scenarios, especially in the genitourinary, we are coming across this particular condition, and he was explaining about this AK versus CKD. Yes, these are almost interrelated. When we don't understand the pathophysiology of the condition, there comes a confusion, and there we'll end up with the acute kidney injury versus what is a chronic kidney disease. Okay,
Okay, sir.
depending on the documentation. Okay, depending on the documentation, yes, as you ask me, in the exam point of view, my principal diagnosis is going to be AKA. I will not go with the discharge summary which is telling about CKD. Okay, because it is already interrelated. The reason for the admission, the present for the admission itself AKA, I'll go with the AKA alone. Okay, this kind of conflict. That is the reason we added the particular examples here. Most we encounter with this particular two scenarios when it comes for documentation conflict. Okay, and the third is like very often you might have encountered right or left.
Yes,
Okay,
sir.
this is something like procedures which we do not have the code separately for right and left. We no need to be worried about. Okay, just we can go with the code and we can code it off. But certain procedures where I need to go only with the site specific means laterality specific codes. Okay, in that scenario, I do not have any other go. I need to go with the right and left way, especially one side, say for example, surgery related and all, mostly they will be talking about them without laterality only. Only we will be appending the modifier like finger modifier or laterality modifier. But for the same procedure code, when it comes for the ICDs, we may end up, especially these ears, eyes, and all. We may have the bilateral code. Sometimes we may have the right and left code. Sometimes we may not have the bilateral code. Only right and left will be there. So there will be a conflict will be there in the documentation. If the documentation is supporting for the right, and where you can code the CPT without indicating the modifier, where you can code the CPT. But when it comes for the ICD, you need to take the specific code. There it becomes the trouble for us. There it becomes the problem for us. So in that scenario, yes, I need to go back and check with the provider and ask for the clear documentation. Okay, this kind of conflicts. Okay, these are the different set of conflict. One is on discharge summary, where you get a conflict between the conditions, or one more is like progression note. Okay, see, based on the progression note and based on the documentation, entire documentation also, there will be a sort of confusion during the diagnosis. So initially I came with one problem, then in the progression note I will be, during the admission I will be no problem, during the discharge I will be no problem. This all will make the documentation conflict. We have to read the documentation and understand entire scenarios. For the two important things are very, very mandatory when you're coding IPDs. One is anatomy, the other one is the pathophysiology of the conditions. Okay, this is very, very mandatory. When it comes for the LT and RT, yes, this is very straightforward. Sometimes within a logical mind, you can code it off, because I do not have any particular guidelines to follow for the right and left on the laterality. As we discussed in the ICD 10 in the section 3 and 4. So we can just go with the documentation. If the ICDs are available, we can go according to that. ICD, if otherwise, we can go with the other specified or unspecified like that. We need to specifically mention about laterality. Yes, I need to get back to the clarification with the physician in the way of provider code. Okay, next thing is like ambiguous documentation. Information is vague or non-specific. So as I told, it is not clear. Ambiguous means we can tell in short. It will be vague or non-specific means the documentation won't be clear. See here, especially when it comes for the IPDRG. See, we are in the CCS. I understand CCS is for the IPDRG almost. Some of the outpatient also is there. Yes, as we seen when it comes for the CCS exam, we will be following the outpatient guidelines also when you're discussing in the ICD. Especially I was talking about this particular thing. Suspected condition, possible conditions, where that need to be proved for the outpatient. When it comes for the inpatient, yes, we can consider that possible conditions or suspected conditions can be considered. Okay. Sometimes you may get incomplete documentation, or the documentation will not be clear, which is ambiguous documentation you may get. In that scenario, it is better to check with the physician exactly what is happened with that condition. So see here some example I provided, possible pneumonia. See, pneumonia is something I cannot tell possible. See, certain conditions, say for example, suspected stones. Yes, I agree. There may be some kind of calcifications, or some kind of what is it? Some kind of scattered abnormalities, or some infiltrate consolidations I can see in the organ. Okay, so based on that, I can tell it is possible. Even if you take for lungs, pneumonia, when the patient is having pneumonia, he will end up with something called infiltrate or consolidation. He's not going to very definitely is going to see the picture of pneumonia. Pneumonia is a combination of infiltrate and consolidation. So other abnormalities combine to form this condition. Okay, this disease. So even that I cannot tell it like a possible pneumonia, which is need to be proved in some way, which is need to be seen, because I'm when it comes for the outpatient, I'm going to do the diagnosis procedure, which is like radiology procedure, either with X-ray or CT and MRI, which I need to see it very clearly. If I don't see it, I cannot do the treatment for that. If I don't do the treatment, how can I can tell the discharge summary possible pneumonia? So this much of thing will be there. Whether I can apply this step of logic, this step of flowchart for all the procedures, all the disease condition, no, it is not like that. Yes, let's say for example, we'll take on stone as an example. I cannot see in this. I cannot see the stone in the ultrasound or CT and MRI in some cases, because the size of the stone. Because of the size of the stone, you will not be able to identify it in some cases. Okay, we need to go till the nuclear medicine. If I go till the nuclear medicine only, I will be able to identify whether the patient is having the stone or not because of the size. But the patient is having the pain. So in that scenario, I'm going to tell patient is having suspected for the stone. So which means like the treatment should have been focused on the treating the stone. Now, when the patient is coming for the kidney pain, I cannot treat for the stomach pain. So when the patient is having the diagnosis as a suspect for the kidney or possible for the kidney stone, I need to give the treatment for the stone only. Because the pain is in the kidney, the flank pain is there. I need to provide the diagnosis or therapeutic for the kidney related only, which means like kidney stone related only, especially. So then I can consider, because the entire procedure is performed for to treating the kidney stone, which is not visible. Maybe after the procedure that may be visible. Okay, so the pathophysiological conditions, see these altered mental status, post-operative complications, these all are something I need to be documented. Renal insufficiency, especially. Renal insufficiency means you may get with the polyurination or oleurination, this kind of symptoms you may get. They may conclude, like physician may tell, like, okay, some insufficiency in the renal. What type of insufficiency? Insufficiency may be renal disease, renal infection, renal cancer, or renal stone also. It can be anything. That is the reason we are getting the renal insufficiency. I cannot tell vaguely renal insufficiency. I need to specify what is exactly happening in the renal. Okay, so like this, whatever the complication or possible pneumonia, these all which are some of the conditions which need to be told very clearly. If I'm not clear, yes, I need to get back to the physician for the query. That is very, very important. So why this ambiguous documentation on topic we are discussing especially means, same time when you think, basically our anatomy knowledge, our analysis knowledge will not be up to the mark. What usually students will do, what coders will do, simply they will query the physician. Now, physician is not only going to sit and read your documentation, he has to treat the patients also so much. When you keep on questioning him so much, what happens to him? He will get irritated. Then he will come back in a different way. That will become a big issue. Okay. So to avoid that, we need to ensure what type of documentation is provided and what is the need for the documentation, or all the completeness is there in the documentation. If it is not there, really is this need to be questioned with the patients, or they need to be questioned with the provider or not? That need to be ensured. So you need to be able to categorize it, whether it is a conflict of the documentation or ambiguous of the documentation. That level of understanding should be there when it comes for the documentation. Simply, you cannot go back and ask, like, possible pneumonia is there, can I code or not? If you see, like, especially when the people, when they query with the QAs, they will ask, Akka, can I code this? Anna, can I code this? That is how they will end up with. They will not ask the question like, this is what in the documentation, this is what in the
Yes, sir.
guidelines.
In
So
ED, we usually won't code possible conditions.
yes, so we need to query very clearly. That is not very, very important. Okay. So not only in the ED, Buna, it is like
Yes, sir.
most of the outpatient. Okay, not most of the outpatient. All the outpatient, we don't code any suspected possible condition. That is what our
Yes, sir.
guidelines. Okay,
Yes, sir.
but when it comes for the inpatient, slight adjustments are there. It cannot tell adjustment. That is what happened. IPDRG means already
Yes,
I'm
sir.
inpatient. When I'm
Yes.
going as inpatient, nothing is possible, nothing is suspected,
Yeah.
because the payment is more, the amount is more. Simply for possible or for the doubtful condition, how I can make you as an admitted patient?
Yes.
So that is a question. And in the same time, yes, this is a medical world. It can differ. The changes may happen. Today I may have the cancer, tomorrow I may not have the cancer. That is
Yep.
possible is there. So today I may get admitted for cancer. Next day I may be discharged for no cancer. So there I cannot think like there is some ambiguous documentation. The required documentation is not there. As we discussed the third point, what is it? Medical necessity is not available. Without
Yep.
medical necessity, we are admitted. Based on the discharge, we cannot. That is the reason they have added this particular guidelines, POA guidelines, present on admission guidelines. They added to avoid this kind of scenarios only. Okay, so this
Yes.
is on the resolving of the conflict or ambiguous documentation in the medical record. And so how to identify the issues? Okay, commonly where are the issues we'll be able to see. So common type. So like a diagnosis conflict, rolled out of the patient, or sorry, rolled out of the pneumonia or acute pneumonia. Status conflict, whether the acuity we can tell, acute or chronic or current or history. Yes, I see most of the people they confused with a patient is coming for the history of cancer. Say for example, history of the breast cancer, without understanding the entire documentation, coming for the assessment or plan, or coming to the impression, or coming with the progression note, depending on the different specialities, okay, or coming under surgery notes, they may come up like a conclusion. History of breast cancer means they will end up with the Z series. Patient in the surgery department, he has come for the surgery, which is a current scenario, so he's coming for the surgery. Since the documentation is told as history of cancer means I cannot code history of cancer. It is a
Yes.
current cancer, that is why he's coming for the surgery. It is going to be
Yes.
the current cancer, that is why he's coming for the diagnosis. Correct?
Yes, sir.
Okay, so we need to analyze. History means he is telling from the long term the patient is having the cancer. That is what they're telling. That is what we call it as history. So we will tell right since 1987, since 1984, which means from that time to this till now I'm running the show. I'm running the what is that? I'm running the shop, which means it's still active only. I cannot think that like an history of the cancer, unless they're doing some lumpectomy, mastectomy, or chemotherapy, or radiation therapy, something like that. If they're doing and treating that in that scenario, yes, I need to consider it as an history. If that is going to be the scenario, they're not going to come for some what to tell for diagnosis purpose or to for the surgery purpose. They're not going to come. Okay, this kind of status conflict will come. There's laterality conflict, as I told, right and left. We need to be very importantly notified based on the documentation. Then the procedure conflict, whether it is operative note or progressive note, we need to be very careful because the progressive note or operative note are going to be different. Because when I'm doing the operation, I will have that one condition. After the operation, the condition will not be there. In the progression note, I will be normal. In the ED note, I will have the cancer. In the operation note, the cancer will be removed. In the progression note, I will be normal. So based on the progress note, if I code, I will not get any payment. Okay, that need to be very careful on that. Okay, then timing conflict, yes. What is the condition occurred during the POE? What is the condition occurred during the hospital stay? That is need to be understood. Then provided disagreement whether the attending physician is performed or consultant is performed, which type of physician is performed, or whether it is assistant PA who has performed, is all need to be notified. Okay. So some of the hierarchy it is given here. Apply the hierarchy of the documentation source. When documentation conflict, follow the clinical documentation hierarchy. Very importantly. So I need to give the first preference to the operating note. As I told, progression note is not much important here. Operating note is very important. And pathology report, discharge summary, attending physician note, consultation note, nursing and ancillary note. Okay, it is not like this. All should be there. The hierarchy should be like this. Okay, so initially operating note, then the pathology note. Why, sir, I should have the pathology note? Very importantly, we were discussing even in the surgery related, a patient may come for the lesion. When I'm sending to the pathology, then only I will come to know whether it's a benign or malignant. Now, based on that, my entire coding system is going to change. So, in that scenario, along with the operative report, pathology report is very important. Where what about anesthesia, sir? And what about diagnostic radiology or intervention radiology, sir? And what about E&M? We don't want those report means after those reports only we are coming for the operative report. So operative is going to become the main. So I concluding something like I'm going to do an operation for this person. When I'm concluding an operation for this person by using all other notes, I don't want to look about other notes. Okay, after the operation also, I need to go for one more confirmation. That confirmation will be done through the pathology report only. That is the reason in the hierarchy, second hierarchy, they provide the pathology report. Okay, discharge summary, attending physician notes, consultation note. These are very important. So after discharge summary, attending physician will be providing you some of the what is that notes, like what is going to be prescription of medicine, what is the plan of management, and what are the follow-ups we have to do. This all will be done by the attending physician. Consultant, after coming up, after for the follow-up or something like that, yes, consultant notes are very important to ensure whether it has come for the conclusion or not. The nursing and ancillary notes, those are also important. Ancillary note, it will tell you the especially when it comes for the primary care. Okay, they focus on ancillary note more than the other department notes. Okay, it's a kind of supportive note we can tell. Initially, I will come to the hospital. Every time I cannot go to the hospital, I will go back to the primary care because I will start my entire procedure process from the primary care. Then only I will go for the hospital. Immediately, I will not go to the hospitals. Okay, like if I will go for the clinic first in our country, then only I will go for the hospital. Immediately, I will not go for some big hospital for the surgery and all, right? So that is what the primary notes also it is important here. Okay, then do not assume or interpret. Okay, very. I used to tell to all the coders, all of my trainees, hundreds of people, thousands of people, I told the same. The thumb rule in the medical coding, the thumb rule in the medical coding is please do not assume at any cost. Please do not assume. First, there should be a proper documentation, and there should be a proper documentation which need to be provided by the physician. Without that, I cannot assume by myself and I cannot think. Most, if you see 80% of the coders, they do the assumption coding. They do the assumption coding. Because of the assumption coding only, the quality will be down. Whatever you're going to code, it need to have the two important thumb rules. Okay. First thing is like, yes, as I told, don't assume. For avoiding the assumption, we need to know the concept. That is the first. The second thing is like, please follow the guidelines. Guidelines will keep you in the control. You will not think out of the box. You will be thinking inside the boxes. You may have the discussions. You may have the different opinions on the guidelines. But at the end of the day, the guidelines is the one which we are going to follow. Okay. So always Never assume the documentation. That is very, very important. Okay. So code must not choose the most severe diagnosis, infer intent to the lab or imaging alone, resolve conflict independently. So this all together. Okay. So which is something like always go and give preference for the documentations which is clearly diagnosed, assessed, and processed by the physician. Okay. So by thinking by our own imagination, by knowing the different concept in different way and in different opinion, we cannot code by our own. That is what very, very critical rule here. Then apply the clinical consistency test. Okay, so this clinical consistency test means nothing, a flow chart. Okay, so first the patient should have some signs and symptoms. Okay, then we need to go for the diagnostic finding. Then we need to check for the what kind of treatment I can provide. Then after treatment, what is the final outcome? So this is a step-by-step process. So once I enter to the registration, after I'm going to the hospital, why I'm going to the hospital? Because I have some headache, some sign and symptom. Then for that sign and symptoms only, I need to do some diagnosis. It can be any set of diagnosis, starting from invasive procedures to non-invasive procedures, anything they may do. Then if I come to know what is the findings, what is the problem I have, I need to go for the treatment. What type of treatment need to be provided? Only with the medicine or with the surgery or with the therapy? I need to conclude with. This is very, very mandatory. Then clinical course and outcome. So finally, what will be my outcome? Whether I will be normal, abnormal, I will be treated or untreated. Okay. So ask which diagnosis is the best matches for overall clinic pictures. Is the condition is ruled in or ruled out or still uncertain? Ruled in or ruled out or still uncertain. That need to be very mandatorily understood. Then only you can able to apply the documentation properly and apply the codes properly. Okay, this determines whether the query is required or not. Okay, so again and again, each and every slide, why we are keep on reading this means I should not go to the physician for questioning them. So before going and questioning with the physician, I need to ensure these all steps so that I will not have any kind of deviations in the coding documentation, especially so the conflict and ambiguous and the analysis of the health records, review of the health records, and identifying the gaps and consistency in the documentation, fulfillment in the documentation. This all need to be mandatorily, everything need to be analyzed. It is not going to take hours. It is going to take minutes, 1 minute maximum, if you know the concept behind all these things. Okay. Then use a complete complaint provider query. Okay, so here something like we will be discussing the provider query little more, but best practice when before going and asking with the physician, as I told, when to query must be. So conflicting the diagnosis, uncertain acuity, uncertain etiology or organism, and unclear relationship between the condition, PO status is unclear. These are the places where you can question with the physician. And when you should question means non-leading, multiple choice or open-ended, and supported by the clinical indicator and clinically clearly dated and attributed. So when you're going to question, it should have these points. Okay. So the question should have the full stop. It should not go further like non-leading means it should not go, you ask one question, physician ask one question, again you ask one question, again he is going to ask. No. It should be non-leading and multiple choice and open end. Multiple choice and open end, I will be discussing in the provider end. Like provider could be the separate topic. We'll be discussing this multiple choice and open and all this little more clearly, like supporting clinical indicators and clear data. Okay, this all we'll be discussing just now for your knowledge. You just know about it. Okay, this is what we have to do when it comes for the querying with the provider. Then example queries are given here. Example, conflicting the sepsis documentation. Okay, see the clinical indicators are fever, trachea, then the provided IV antibiotics, blood culture is negative. So documentation reflect sepsis and IRS rolled out. Based on the clinical findings, please clarify the final diagnosis. So what I would take here, I will go with the all this set of conditions, because these indications, okay, what are the clinical indication they provided, it can be related to so many conditions. Yes, some conditions I provided like sepsis, SARS, localized infection, condition ruled out and other we have provided, but tachycardia and fever, it will be related to the so much of condition. Now how I can narrow down based on the clinical features like providing the antibiotics for fever and trachea. If it is related to the heart, I will not provide antibiotics. Antibiotics is provided for the infection. So when you have the infection, you may end up with the fever. That is very mandatory. Possibly you may end up with the tachycardia when you are having the inflammatory syndrome. Okay, that is a possible. So now you are not clear because this is a fever, tachycardia, including IV antibiotics. These three are very importantly, you can relate to the sepsis as well. Okay, not only for the sepsis, MRSA, like methicillin resistant conditions. Okay, some other infections also we can relate. Okay, now I'm giving the choice for the physician because I just cannot tell this is the indicator, what is the condition, I cannot ask. My query should be very clear. I need to decide based on these clinical features. I need to decide there may be the possible these three condition. Now keeping these three conditions as a choice, okay, as we seen here, the choice, multiple choice or open end. Keeping that in the mind, we have to give some three choice for the physician so that he will choose one, which condition it is. Okay, that is what the first query is telling about. First example is telling about. And second is like ambiguous renal documentation. Renal insufficiency. I told no, renal insufficiency means what problem insufficiency means? Injury or disease, acute or chronic or infection, what it is. That need to be very clear. It should not be very vague. It should not be non-specific. It should be very clear. That is what ambiguous renal documentation. Then conflict in the laterality. Operative report indicate right knee arthroscopy, while consent note left knee. Please confirm the correct laterality. Yes, in this situation, definitely I need to verify whether it is the right side or left side because performance done in arthroscopy performed right side, but notes are telling in the left side. Okay, then identify the missing or insufficient documentation. One more topic. So this is like understanding the fundamental difference between absent record and the non-specific clinical documentation. Okay, so far whatever we have seen is like non-specific, which means like ambiguous part. We are discussing about the documentation which is not very clear. Here there is a small variation, there is a small gray area where the documentation is not really there, or it is possible condition, or it is a ambiguous documentation that we need to identify. That is what this main topic is talking about. Identify the missing or insufficient, whether it is completely missing or physician is not documented it. How I can able to understand that? Okay, that is what they're trying to give a clear picture here. If you see missing documentation, required element in absent, no discharge summary for the inpatient stay. No discharge summary for the inpatient stay. So it says very clearly, this documentation is not available. This documentation is not available. When it comes for the insufficient document, element exists but lack the specificity or clinical support. Okay, so these documenting, say for example, we'll think it like a kidney failure. Whether it's acute kidney failure, chronic kidney failure, heart failure, whether systolic or diastolic or it is a congenital heart failure, it is insufficient documentation. That is the difference between the missing and insufficient documentation. Missing means completely will not talk about the entire documentation won't be there. Okay. When it comes for the missing documentation, it will not affect the payment. But insufficient documentation, definitely it is going to affect the payment because I cannot do the unspecified code when I can able to code it as a specific code. Okay, here one example, recording anemia without documenting specific type. There's so many type of pneumonia, the sickle cell anemia, Tarsania anemia, right? Age-related anemia, chemotherapy anemia, cancer anemia, so many anemias. What anemia it is, that need to be documented. When it is insufficient, it is going to be affect the billing. We need to go back and query back. Okay, so here as I told, missing completely not available, insufficient it is available, but it is not provided completely. Then understand the documentation requirement for the specific diagnosis or procedure. Okay, so essential documentation required for the acute healthcare record and coding integrity across the diagnosis and procedures, a comprehensive guide for the health related healthcare provider on the critical elements needed to the high quality medical documentation. It's very simple, nothing. What I'm trying to tell is like, make sure you're providing the clear documentation. Make sure you're providing the clear documentation. If you see here, sepsis, severe sepsis, septic shock. Okay, why am we are keep on telling this example, sepsis, severe sepsis, and septic shock means in inpatient coding, this is having the weightage. This is having the weightage for all set of procedures which they are performing because patient who were undergone for the procedure, there is a 10 to 15% of the possibility where they may end up with the infection. Okay, that infection is going to be the sepsis infection. That is the reason we are repeatedly seeing the examples on the sepsis, septic shock, and severe sepsis. So here required documentations. Okay, explicit diagnosis and clinical indicator are mandatory to support a high acuity specific septic condition in the medical record. So which is like I need to specifically need a documentation, supporting documentation to apply POA. Okay. See here, the diagnosis by the explicit diagnosis by the provider, source of infection, organ dysfunction, vasopress used, and POA status. Now, this is like not interfered, source of infection, organ dysfunction, like this severe sepsis it is indicating. Vasopressor use, which is like when it comes for the septic shock, we are going to use the vasopressor. So these all are the documentation required, okay, for the considering for the sepsis or septic shock or severe sepsis. Next, if you see, patient is having the fever, hypothermia, which is like a elevated WBC, positive culture, antibiotics and fluid is provided. Here, common gap. What is a gap? Systemic syndrome, okay, like responsive syndrome due to infection without sepsis stated, no source of documentation or organ failure not linked to the sepsis. So here we are looking for the sepsis related condition, but whatever the condition they provided, it is supporting for the normal systemic inflammatory response syndrome. Okay, in that situation, I will not be able to understand what type of infection he is having. That is a major gap. Okay, there is a major gap we can able to identify. Having the clinical documentation, having the clinical supported documentation, still I may not be able to conclude what type of sepsis, because I will be able to conclude only it as an inflammatory response syndrome. But for happening for happening SARS, what is the main set of condition? What is the main set of infection happen? What is the acute happened here? Whether it is a sepsis or severe sepsis or septic shock is not clearly documented. Okay, that kind of gap you may encounter when it comes to the sepsis. Okay, then acute respiratory. Here, mostly if you see acute respiratory, whether it's a hypoic or hypercapionic, which means like hypoic means less oxygen, hypercapionic means less carbon, so more carbon dioxide. Okay, hypercapnic. Okay, hypercapnic means more carbon dioxide. So accumulation of more carbon dioxide is also a problem. Accumulation of less accumulation of oxygen is also a problem. So now that need to be very clearly documented. Yes, I know it is an acute respiratory failure. For what reason it happened? What reason it happened? Because of the hypoxia or hypercapnic. For which reason that is happening? Okay, this kind of specificity is very, very mandatory to understand the documentation, to come to the conclusion for the documentation. And if you see here, explicit diagnosis required acute respiratory failure must be specified hypoxic or hypercapic condition, include clinical indicators such as ABGS and SpO2 levels, treatment, the detailed treatment used, BAPAP and vent or high flow. So when you see all these things, I know it is an acute respiratory failure only. There is no doubt in that. But what type of acute respiratory failure? That need to be identified. It may become the chronic also. I need to identify what type. So that much of documentation is very much mandatory. And same way in the acute kidney injury also, yes, by keeping the level of the creatinine and by keeping the what is that flow of the GFR rate, okay, I can come up with the conclusion of some condition. Especially I may come up with the AKI, but whether it is going to be in the short time or long time, whether it is growing, developing, or it is stopped, whether I need to go for the further IV fluid or whether I need to go for the analysis, dialysis, all these things need to be verified. Okay, that verification, entire verification process, it should be happen in the acute kidney injury. Then heart failure, as I told, acute is very, very important. Some of the examples we are seeing for the same. Okay, here, systolic, diastolic combined. So what type of acuity that is? That need to be there. Then ejection fraction, where it should be documented. When they are documenting about the gallbladder or they're documenting about the heart. Okay, in that scenarios, they need to talk about ejection fraction value so that we'll be able to identify what type of condition, especially in the heart, this ejection fraction value will be used to identify systolic or diastolic. This all need to be identified with the help of clinical matrix. Then diabetes mellitus, yes, as we know, there are different type of diabetes mellitus are there. So we need to ensure through the test whether it is a type 1 or type 2. Okay. So these all complications, these all things we should be able to identify with the help of the proper diagnosis and analysis. Okay. Just a minute. Okay, so we need to specify what type of diabetes it is. Okay, it is what type of induced it is, and what type of control measures we are taking, and what type of treatment and what type of follow. Okay, and what is it is complications, what type of complication it is leading to. This all need to be identified in the documentation. If it is not there, again it cannot be vague, it will become an incomplete documentation, or you will find a conflict in the documentation as well, and we can tell it is an ambiguous documentation also. Okay, then malnutrition. Yes, in the malnutritions also, degree of malnutrition need to be documented, and what is assessment is performed, who is the dietitian, what is the dietitian assessment is there. One side, my physician will tell me with some kind of measures what type of what degree of malnutrition I have. Even though I have the documentation, I need mandatorily documentation from the dietitian. This assessment is very, very important. Without this assessment, I cannot just go with the whatever the other profiles which are like weight check, loss of weight, and BMI, okay, body mass index. Through that, I will not be able to come for the conclusion. So the documentation should be very clear. It is like a bridge between the dietitian assessment and with the physician. Stroke and CVA, yes, even this we need to know whether it is an ischemic or hemorrhagic. Okay, ischemic means whether it is because of the infarction or it is because of the overflow of the blood, the stroke is happened. Which location and which laterality. Okay, whether it is a old one or new one, when it is occurred, and whether it is a residual or it is going to be move away from the veins or from the soft tissue. Okay, this much of documentation is required, like type, location, all this need to be documented to identify what type of stroke and where the stroke is present, whether it's a new stroke or old stroke. Okay, so these are the some of the example on the documentation. Mostly we will be encountering the documentations that we are seeing here. Then what we are seeing is like procedures. So far we have seen in the diagnosis. Okay, like what are the documentation requirements when it comes for the specific diagnosis. When it comes for the procedures, what are the specific documentations required, what and all should be seen when I go for the performing the procedure. The first thing is like surgical procedure. So when it comes for the surgical procedure, preoperative and post-operative diagnosis is very, very important. Then approach, site, and laterality. Okay, simply I cannot go and do the procedure. When I do the surgery, I need to know what is the diagnosis. After the surgery, what would be his diagnosis, and what is the approach, site, laterality, devices used, or any complication is there. These are all very, very important. Without this, you will not be able to code, especially when you are coding the IPDRG. Without knowing the device and all, we'll end up with the incorrect PCS codes. Okay, so we should have these all things. See, this approach, site, laterality, device. Without this four, you cannot be able to do the PCS codes. Okay, even CPT we can able to identify. Okay, without a device, with the help of approach, site, and laterality, we can come to the conclusion. But when it comes for the PCS, device and approach is very, very mandatory. The next is like endoscopy and colonoscopy. When they're performing the endoscopy and colonoscopy, whether it is reached, okay, whether it is performed through the mouth or through the anus, what type of opening they have taken, like whether they made some incision or whether they went to the natural opening or whether any artificial opening is there, that need to be there. And what type of findings and what type of therapy, whether it is performed for the therapeutic purpose or diagnostic purpose, that also need to be identified, documented. Then size and location of the lesion or biopsy or the condition which are they going to identify. Okay, these are the important things which we need in the endoscopy and colonoscopy. And imaging guidance. Okay, like imaging, especially in the radiology, the most important thing is like supervision and interpretation. We call it as supervision and interpretation. The physician need to review the entire documentation. We need to provide the interpretation, and to perform the procedure, we need a medical necessity and final interpretation. That is the impression of the documentation need to be there. Comparison documentation need to be there. Laterality documentation. Yes, sir. So especially when it comes for the diagnostic related, if you have gone for the hospitals for the diagnostic related like ultrasound, the physician used to ask us, do you performed ultrasound previously? Do you have any report previously? Because the comparative analyzations will be done. Comparative correlations will be done through the diagnostic radiologists, and the documentation will be appended there. Okay, so here the rule is final report, not the preliminary report. So code based on the final report, not based on the preliminary report. So medical necessity, supervision, interpretation, laterality, comparison, technique, these all are very, very important for the imaging, which is in the radiology. Then anesthesia. When it comes for the anesthesia, who provided the anesthesia? Whether it is provided by the anesthesiologist or it is provided by the certified registered nurse anesthetist. Okay, so that is also we have to check. Okay, so who has provided? Sometime even the surgery physician itself provide the anesthesia, or anesthesiologist will provide, or registered nurse anesthesiologist will be providing the anesthesia. So who has provided? Based on that, we have the modifier. Based on that, we have the code also. Then status. So P1, P2, P3 status need to be indicated. Severity of the condition will be indicated. Then type of anesthesia, whether general anesthesia, regional anesthesia, or monitoring anesthesia control, they have provided MAC, which is performed or not, that need to be identified. Then record like start time and stop time. Yes, without start time and stop time, anesthesia report is zero payment. Okay, so that is also very, very mandatory when it comes for the procedure based documentation requirements. Okay, then critical care. Okay, so it is under the E&M. In the E&M, one of the important thing from the ED that will be converted to the critical care or urgent care. Here, when you come for the critical care, we need to check active management of the organ failure. Exclusive time documentations are required for the critical care code. Yes, these two are time-based codes, which is very, very mandatory. Okay, so patient critically ill with organ failure, provided time documentation exclusive for the service, active management provided by the clinician, not sufficient, which means a high acuity diagnosis without critical care management. Okay, so when it comes for the critical care, appropriate documentation, especially organ failures, whatever the failures, whatever infections need to be documented. Then what is the active management? It is not like something like previous management or previous treatment I need to consider. Active management need to be considered. Okay, those are the needs for the critical care. Same way for E&M. E&M very simple. MDM table. COPA data risk. Okay, these three are very, very mandatory to code the levels of the E&M. Then comes procedure required. Okay, some of the procedures, especially when they're performing the what is that, the critical care procedure and other observation services. Okay, so what are the requirements it is required? So as we told, time related procedures are like critical care is one of the time related. Even E&M we can consider for the time related. Anesthesia we can consider for the time related. Then observation services. Okay, certain services like infections, tuberculosis, or cataract replacement and retinal replacement. These are all things we need observation. We cannot just do the procedure and send it out. Then short start time and stop time. Yes, not only for the anesthesia, even for the procedure, surgical procedure, we need start time and stop time need to be documented. Then record for the provider presence throughout. Yes. So whether the procedure is performed by the one physician or different physician, whether the entire procedure is performed by one physician or with the support of nurse and all these people were there. So these all need to be identified in the procedure. These are the requirements for the procedures. Then gap. Okay. So something we can tell like identifying a correcting the gap. So identifying the gap in the documentation and correcting them is also one of the important criteria. Okay. So identifying the disconnect between the diagnosis and a procedure, ensuring the record integrity and patient safety. Yes. So why we need to identify the gaps, okay, which is like which will ensure patient safety, in the same time it will provide a proper reimbursement. First, linkage gap, procedure performed with the diagnosis without treatment, or medication without the indication. These are the linkage gaps. So very simple. Procedure performed without diagnosis without treatment, or medication without indication. So I cannot do by my own. Whenever, wherever required, in that scenario only, I need to do the diagnosis, do the treatment, provide the medication. Without that, I cannot just assume myself and provide it. Okay, that is what the first thing. And second thing is like when to query. One side linkage, and other side is query. So when it comes for the query, just a moment. Sorry, Bono. Okay. So this is on the next thing, like when to query. So as we discussed earlier, yes, if we lack the proper diagnosis and there is no clear documentation, or there is no proper indicators in the documentation, or documentation is completely incomplete. Yes, that is a situation where I need to go back and query the physician. Okay, so when I'm going to query the physician, I need to be very careful. Okay, based on this, we'll see furthermore some of the examples so that we'll have a clear cut understanding what are the diagnosis documentation gap is there, and how that can be clear, and what is the linkage gap is there, and what are the queries we have to do. Okay, so when you come for the diagnosis documentation gap, okay, these are some of the example documentation, very frequent documentation we have seen, especially when it comes for the diagnosis. One is the chronic congestive heart failure, whether it is acute or chronic or systolic or diastolic, that we need to be very clear, that specificity need to be documented. When it comes for the sepsis, source of the infection, and what type of organism that need to be documented, then type of diabetes, where it is a complication, what is the status, something which you have seen already. Again, we are making into the separate topic when it comes as an documentation gap. Then other gaps such as like administration and legal elements. Okay, here if you see, especially like a patient initial, patient name, last name, middle name, date of service, provide a signature. Okay, then whether it is performed by the MD or doctor office, or by the physician assistant or nurse practitioner, who has performed the procedure, who is the authenticator person to perform the procedure, who need to be authenticated. These all are the documentation, very, very important. Okay, this kind of gap also we may get. That is what administrative or legal element gaps we may encounter. Then next is related to the history and the physicians. Okay, when it comes for the history and the physician, yes, physical deficiency, so we need to ensure complete HNP, okay, complete patient past history, and physical documentation on ROS, okay, the review of the system. These all need to be documented very clearly. Okay, without that proper documentation, we cannot go. Okay, here sometime what happens, the format will be same, the documentation formats will be same. Physician used to copy paste. Okay, that need to be avoided. If you don't do that, what it will end up with an improper diagnosis, it will end up with the improper prognosis notes. Okay, so these are very, very mandatory, where we may get the gap in the patient history and the physical exams, so which may be incomplete. By keeping that incomplete documentation, we cannot proceed further. That kind of gap may be happened. Then next, if you see clinical notes and progression note and clinical courses. Progression note, what type of treatment, what type of management, whether it is active or so, whether it is diagnosis or done, whether the assessment is required, follow-up is required. This kind of progression note should be there. And a clinical course. Clinical course means everything, like whatever the procedure they're going to perform, after doing the procedure, whether this is going to be completely concluded or completely healed, or I'm now going to put it in the red flag, because it can be a repetitive, or it can be improved, or it can be become a side effect, or it can become the complications. Okay, this can go clinical course I need to provide after doing the procedure, after doing the treatment. I need to give a clear documentation. If I don't provide a clinical documentation, yes, I will not be able to provide a proper discharge summary. If I don't have the clear discharge summary, I cannot be able to go for the proper payment. Okay, so that is what the gap we may encounter. Documenting the active management, patient response to the treatment on the daily basis is very, very mandatory. Then diagnostic test documentation was very, very important here. Yes, sir. Without this, I cannot go further step. No procedure, operative note, no pathology note. My diagnostic, like laboratory test or imaging test, which need to be very clear, very clearly that need to be interpreted, very clearly interpreted by the physician, and very clearly the documentation need to be provided, and impression of the images, and clinical interpretation for the laboratory test that need to be provided. Based on that, what is the abnormality, what is the preliminary test I need to take, what is the continuous test I need to be provided. This is all very, very important. Okay, so diagnostic text documentation. Provider's role in interpretation and acknowledging the abnormal clinical findings. Okay, so if you find one problem, you should ensure there is a proper imaging guidance, imaging is there, and the documentation is there, imaging documentation and interpretation is there for that, and pathological report is there. This all need to be documented very clearly to go for the further progression in the procedure. Okay, based on that, in the procedure, I need to go for the operative documentation, procedure documentation. It should be very clear, very precise. Then only I can be able to bring the CPT and ICD accurately, even ICD 10 pieces codes accurately. Otherwise, I will be end up with the improper codes, which will impact my complete reimbursement. So, absence of formal operating note in the record, missing the details on the surgical approach and laterality and specificity, and the mismatch between the pre-operative and post-operative diagnosis, and incomplete description of the device used or surgical techniques, okay, which all may impact for the incorrect CPT, ICD, all these things. Okay. Then medication and treatment. It's not about only like they're doing the procedure. Provider clearly should have the clinical rationale, which means clinical rationale means clinical explanation. Okay. Documentation related explanation, condition related explanation, why he is doing the treatment and what type of treatment he is doing, why he is need to provide this medication and treatment for this particular patient. If we have that gap, and again that is going to be a problem. No clinical indication documented for the administered medication, then IV fluids, okay, IV fluid or blood transfusion admitted without supporting documentation, oxygen therapy provided without a documentation of respiratory condition, and missing start and stop time for the time-based clinical services. Okay, these all are very, very mandatory. See, overall, if you see, overall, we are trying to picture how the documentation should be complete, how the gap should not be there, so that without any problem, I'm going to code. Okay, next is like POA and HAS and PSI. Okay, like these all are the indicators. Okay, so when it comes for the POA, as we discussed in the POA, so present on admission. Okay, that is very, very important. We need to be understanding what is the principal diagnosis for the patient for admitting. Okay, and next is like HAC, which is like hospital acquired conditions. Okay, during the hospitalization stay, what are the condition acquired, whether it is going to be the primary condition or it is going to be the secondary condition. Okay, that need to be identified, which is very, very mandatory to understand which is the principal diagnosis and which is the secondary diagnosis can be identified. And the third one is like PSI. Okay, so PSI, which will tell you like this indicator, this is an indicator, safety indicator, patient safety indicator, which will tell you whether the eligible CPTs or whether the eligible ICD or whether the eligible EPIC score, whichever used, which can be used for this patient or not. If I don't use it in a proper way, finally I will end up with the penalties. Okay, financial penalties will be there, or improper payments will be end up with. Okay, so even PSA will be discussing POA, PSI, HAC, this all we'll be discussing. Okay, present on admission, patient safety indicators. Some indicators are there that I will be telling you, that indicator, then hospital acute conditions. Okay, so these all things we need to be very clear. If you are not clear with that, we will be ending up with the financial penalties and financial incompatibilities. Okay, so these are the one of the documentation gap which need to be very careful. Okay, then the final thing is like discharge summary. Okay, in the discharge summary, it should meet UHDDS requirement for the final diagnosis and hospital code summary. Missing the final diagnosis and hospital code summary, course of summary, and procedure performed during the stay are not listed, or conditions at the time of discharge is not documented. Follow plan and next step of patients are absent, and the UHD requirements like final diagnosis must be reflecting the condition after stay. Okay, these all are very, very mandatory documentation when it comes for the discharge summary. Without this, we will not be able to come to the conclusion. So we need to ensure, okay, we need to ensure, yes, we are finding all this step-by-step process, starting from to identify the gap, okay, to identify the gap from the starting from diagnosis of documentation and administration legal elements, then H&P deficiencies with incompleteness, then progression note and clinical course, then diagnosis test documentation, procedures and operative documentation, medication and treatment, and POA, HAC, and PSI documentation. Okay, so all this step process we need to be able to identify and correct the gaps. Okay, with these gaps, we'll not be able to come to the proper conclusion. Okay, so this is on the entire domain 2, where it is covered for review and analysis of health record documentation and resolving the conflict and or ambiguous documentation in the medical record, then understanding the documentation requirement for the specific diagnosis and the procedure, and finally we are talking about the topic of identifying the and correcting the gaps and the linkage gap between the documentations. Okay, this is what I entire domain 2 will speak. Based on this only, we are going to get the questions. Okay, so we need to ensure we are understanding. See, this is something not like some concept we need to there. Generally, if you feel, if you think, if you understand these topics, it is more than understanding. It's based on your experience also, you can bring it some conclusion. Okay, these are the requirements in the documentation. So the questions are going to be surrounding around this. Okay, they may ask you the questions depending on this. So what I suggest you, go back and take the questions in the domain 2. Okay, some 30 plus questions will be there, and it will provide you additional clarity. And the same thing you're going to apply in the mock exams also. Through the mock exams, you're going to apply the same in the exams. If you do this step-by-step process, okay, you are 100% you're going to pass with the good score. Okay.